Welcome to Global Connections with Robert Siegel, navigating the new normal, presented by the American Friends of Rabin Medical Center. Our monthly Leaders Forum addresses vital issues facing society and technology, real estate and medicine, technology and science. My name is Dr. Joshua Plowman. I'm the Executive Director of American Friends of Rabin Medical Center, AFRMC, a 501c3 national American charitable organization based in New York City. We at AFRMC represent Israel's premier hospital, Rabin Medical Center in Petah Tikva in Greater Tel Aviv, the leading institution named in honor of Prime Minister Yitzhak Rabin. The hospital is a model of coexistence, as it serves 1 million patients annually from all ethnic and religious backgrounds with the same compassionate care. Please support our mission in this free public affairs program with a donation of any amount. Visit us, American Friends of Rabin Medical Center, online and donate at afrmc.org. Join us on social media, on Twitter, Instagram, LinkedIn, YouTube, and Facebook. We depend on you, our audience's support, to help the hospital in Israel. So thank you if you can contribute any amount. Our host and moderator for Global Connections is Robert Siegel, former host of All Things Considered on National Public Radio for 31 years. Over the course of an hour each month, Global Connections features guests who Robert Siegel interviews as they explore important issues in our world. Today's Global Connections topic is new cancer therapies and medicines. Thank you to our very special guest, Dr. Susan Domchek, Executive Director of the Vassar Center for BRCA at the University of Pennsylvania. Dr. Larry Norton, Medical Director of the Evelyn H. Lauder Breast Center at Memorial Sloan Kettering Cancer Center in New York. And Dr. Yael Goldberg, Deputy Director of the Recanati Genetics Institute at Israel's Rabin Medical Center. And now, Global Connections with Robert Siegel.
Thank you, Josh. This has become an annual event at Global Connections, and based on the past two panels we've held observing Breast Cancer Awareness Month, it promises to be yet another fascinating one. The connection for us is a natural one. Global Connections is produced by the American Friends of Rabin Medical Center in Israel. Israel and the U.S. are home to the world's two largest Jewish communities, and certainly to the largest communities of Ashkenazi Jews. Ashkenazi Jews, Jews with roots in Eastern or Central Europe, disproportionately carry the BRCA gene, which greatly increases the risk of cancer, breast cancer, ovarian cancer, prostate cancer, and others. Earlier this year, President Biden renewed what he calls his cancer moonshot, invoking President John F. Kennedy's call to reach the moon within the decade. In this case, the target of the moonshot is to cut cancer deaths in half over the next 25 years. Well, what's new in cancer treatment and research, especially links between cancer and genetics? As always, we've assembled a terrific panel of experts, and you can pose a question to them if you're watching us live on the Zoom webinar by using the Q&A button on the bottom of the screen. Our first panelist is no stranger to Global Connections. She took part in our prior October panels observing Breast Cancer Awareness Month, Dr. Susan Domchek. Dr. Domchek is an oncologist at the University of Pennsylvania. She is director of the Vassar Center for BRCA, also the Vassar Professor in Oncology at the Perelman School of Medicine at Penn. And she is always very enlightening. Dr. Domchek, it's great to see you once again. Thanks for doing this.
Thanks for having me.
Let's start with the annual question, which is what's new? What's something that's going on, in this case, related to BRCA-related cancers, that, to use President Biden's analogy, gets us a little bit closer to the moon?
Absolutely. Well, one important thing to realize and just to emphasize is that breast cancer deaths are down by 40% over the last decade or so. And so we have made substantial progress, and you're going to hear more about that over the course of today. From my perspective, what's really new related to BRCA-related breast cancer is that we've moved forward these drugs called PARP inhibitors to take them up earlier into the course of a patient's disease. So these drugs called PARP inhibitors target, if you will, the Achilles heel of BRCA-related tumors. And they basically attack a different type of DNA damage repair, having, if you will, a double hit of the cancer cell so that that cancer cell can't sustain both a BRCA mutation and being exposed to this PARP inhibitor. So we had studied these drugs in advanced cancer, breast cancer that had spread outside the breast into the bones and the liver, the lungs. And these drugs were shown to be effective. They shrank tumors and they decreased the time that increased the time it was for the cancer to progress. And these are all really good things. But what we really want to do is use these drugs to help cure people. And for that, we need to give these drugs earlier. So in the past year, what we've been able to show is that when we have BRCA1 or 2 mutation carriers who have early stage but high risk breast cancer, after they get all their other treatment, if we then give them a year of a drug called olaparib, which is a PARP inhibitor, they have a decreased chance of their cancer coming back, and they have an improvement in overall survival. So this is a really big deal, and it means we need to know which breast cancer patients have BRCA mutations so we know whether or not to give these drugs.
Since I'm obviously in way over my head on the oncology here, let me just make sure that I understand what you're saying. That a PARP is an enzyme that helps a tumor repair its DNA, presumably after the tumor has been treated. You've knocked it out so much. So the PARP is a bad guy, and PARP inhibitors are kind of a double negative. They block the enzyme that helps the tumor counter the effects of the treatment.
Yeah, it's always interesting to talk about, good and bad in this regard. So BRCA, for instance, we all have BRCA1 and 2 genes, and they make proteins that are good things. They help repair DNA damage in the cell. But if you are born with a bad copy or a mutation, then your tumor cells can't repair that particular type of DNA damage. So in this case, PARP, which is usually good and helps repair that damage, helps sustain the cancer cells. So if you block it, you basically, it's this concept of synthetic lethality, that if you have one DNA damage repair pathway that's not working, it's okay. The cell can use the backup mechanisms. But if you block a second pathway, the cell can't sustain both of those DNA damage repair pathways being blocked. So it's this really amazing translation of basic science where people working in yeast figured this out, not knowing that 20 years later, we would figure out how to apply it to humans.
When we talk about BRCA gene-related cancers, we're talking about a subset of cancers, as you mentioned, and it's a minority of cancers, but having a BRCA gene elevates the risk by a stunning degree. So I know I always ask you to do this, but run a few numbers past us. I mean, if somebody's carrying the mutation, how much more likely are they to experience whatever?
It's a really important question. So BRCA1 and 2 are different genes, but they give rise to similar but not completely related syndromes. So for BRCA-related breast cancer, the lifetime risk is up to 70%, which is compared to in the US about 13% lifetime risk of breast cancer. So that's a massive elevation in risk. For ovarian cancer, the risk for a BRCA1 mutation carrier is up to 45% compared to 1 to 2% in the general population. There's also substantial elevation in prostate cancer, particularly for BRCA2 mutation carriers. And the thing about the prostate cancer is that this is an aggressive form of prostate cancer. So if you will, the kind of prostate cancer that men die of, not that men die with. And so the risk is elevated, but more importantly, it's a more aggressive form of prostate cancer. And the risk of pancreatic cancer, particularly for BRCA2 mutation carriers, is approximately 7% compared to 1 to 2% in the general population.
When you mentioned that most striking number, the 70% likelihood of developing breast cancer, That still leaves 30% of people who have the gene and don't develop breast cancer. I don't know whether it means because they were lucky or they got run over by a bus before they could get breast cancer or what happened. Do we understand why some people can have the gene and not develop the cancer?
We understand a little bit, but not as much as we would like. So we do know that there are other modifiers of risk, and some of those are genetic modifiers of risk. So there are things called single nucleotide polymorphisms, which are little changes in the genetic code, which only alter your risk by the tiniest of amounts. So any individual one is unimportant, but we now know about 300 of them. So you can imagine if you had all 300 good ones versus all 300 bad ones, your risk can be different. So we do know that people who don't develop breast cancer, who are BRCA carriers, are more likely to have, if you will, these good SNPs, or another way to say it is a good polygenic risk score. But that doesn't explain it all either. We do think that environmental factors play a role, but in general in cancer, if for breast cancer, maintaining a healthy weight, minimizing alcohol, getting a lot of exercise, these are all things that are helpful. We know that having your children early decreases your risk of breast cancer, although that's complicated in mutation carriers, and that's not something that we generally plan around our breast cancer risk. Right. So all of these things sort of play together in a complex way that we haven't entirely untangled.
How much does it help to know that somebody carries one of the two BRCA genes?
A great question. It helps a lot. So although our strategies are at this time, insufficient, meaning that the best ways to decrease your risk of breast cancer are to undergo a bilateral mastectomy to remove your breasts. But even if you don't do that, and that is a choice, not a requirement, we know that if you get routine MRI screening, that we can detect cancers earlier at an earlier stage where they're much more likely to be curable. For ovarian cancer risk right now, our single best strategy is removal of the ovaries, and we do remove that at earlier ages, so women do undergo premature menopause. So these aren't sufficient ways to manage risk. We need better ways to manage risk. But at this time, if you know that you have a gene mutation, we can impact how likely you are to die of cancer because we know that information.
Obviously, this points to something we'll be hearing more about throughout the hour, which is screening and screening people whose family histories might suggest that they too might carry a BRCA gene. But the COVID pandemic, in addition to creating this series of panels, has been a kind of national stress test for public health agencies when it comes to screening, whether it's for BRCA or whether it's testing people for a new virus. How well or how poorly does the U.S. do?
We absolutely could do better. That's for certain. And I think we're going to hear later from Dr. Goldberg about what's happening in Israel regarding genetic testing. Implementation, how you actually roll out a process of wide-scale testing is complicated. And you have to be able to do it in a way that doesn't impact disparities and that you actually have an easy way to have appropriate follow-up care. So this is complicated in the United States where, some people have insurance and some people don't have insurance and people have different types of insurance. So we have this added, particularly messy component on top of just the logistics of trying to implement these screening processes. So I think you'll hear that, Israel has, and in part because of the fact that individuals of Ashkenazi Jewish descent have a high chance of having a BRCA1 or 2 mutation. They're further along in these ideas of population screening than we are in the United States.
Should screening be part of, say, a physical? I mean, should a primary care physician be the one who is administering some kind of a test for this, or should one wait to see if there's a cause to test someone?
Well, right now we are missing an enormous amount of, if you will, low-lying fruit. there are so many people who meet current criteria for genetic testing that aren't getting tested. So for instance, all it takes is to have a first-degree relative with ovarian cancer, metastatic prostate cancer, pancreatic cancer, breast cancer under age 50. There are all these people in the United States that meet those criteria that are not currently getting testing. So, there are different strategies about how to do this. We at Penn, for instance, have a number of strategies using the electronic health record so that we can identify those individuals who haven't been tested yet and make sure that they get tested. We're in a large health system, so we have primary care doctors and gynecologists. So we're really working closely with them, to use, if you will, the dreaded electronic health record to our advantage, so that we can identify people who should be getting testing. So it's the other challenge that we've had is that over the years, more and more and more genes are added to these panels. And there are genes that have very different connotations than BRCA1 and 2 and have to be more, we have to be a little bit more thoughtful about doing testing for them. So I think that there's a lot of debate about, if we do population screening, which genes should we include? Who exactly should get that testing? At what age? Who should do it? Primary care doctors? It can't be genetics people in their ivory towers. It has to be done differently. So we have a lot of ongoing studies looking at this. One of the studies that we did was with Dr. Norton's colleague, Dr. Offit, doing a digital health platform offering Ashkenazi Jewish individuals testing. And so we're trying different strategies so that we can get testing out to as many people as we can in the most efficient manner.
Well, Dr. Domchek, thank you very much. Hang around, because in about 20 minutes, we'll have the more open Q&A discussion with all the panelists. But thanks so much for your contribution so far.
Thank you so much.
Okay. Our next panelist is Dr. Larry Norton of Memorial Sloan Kettering Cancer Center in New York. Dr. Norton is a medical oncologist. He is Senior Vice President of the Office of the President of Sloan Kettering. He's also Medical Director of Sloan Kettering's Evelyn H. Lauder Breast Center. Dr. Larry Norton, thank you very much for joining us today. It's
great pleasure to be
you
here. Thank you, Robert.
And on the question of new developments, of what's new, this summer, there was some news of a medication and some very encouraging results reported by a colleague of yours. What happened?
Oh, I think you're talking about we call it TDXD. It has another unpronounceable name, so we don't call it by that. The brand name for it is Enhertu. And I think that's probably what you're referring to. This is actually remarkable. As Susan said, science works. And as we learn more about cancer, we can develop better drugs to actually treat cancer and hopefully prevent cancer, and the whole spectrum of approaches that we can use. And this is an example of that. What this drug is an antibody that can attach onto the cancer cell. And when it attaches onto the cancer cell, and it attaches only on a particular part of the cancer cell, and that's a molecule called HER2. And maybe 25–30% of breast cancer cells have an abundance of HER2. But a significant percentage of breast cancer cells have less than an abundance, but some presence of HER2. Now, for the cancer cells that have a lot of HER2, we've had very good therapies for a number of years for them, because the cancer cells that have a lot of HER2 in them require that HER2 for growth. So that when we attack the HER2 and turn off its function, the cells go on to die. And we've had a number of treatments for that, antibodies and other kinds of drugs called small molecules that can attack that. Very recently, we've discovered another way of attacking cells that have HER2, and that is to have this antibody. And antibodies are the proteins that your body normally makes to fight infections. We can now make antibodies outside of the human body in the laboratory, and we can make an antibody to the HER2. Actually, a very same antibody that we use to stop HER2 in cancer cells that have a lot of HER2, and the same antibody, but it's attached to a poison. That when that antibody attaches, that poison can get into the cells and kill them. And not only that, but that some of that poison can be released in very low concentrations in the surrounding tissue and kill other cells that are in the vicinity of the cancer. A lot of people think that cancer is just a bunch of cancer cells, and it's not. Cancer cells are part of what makes cancerous tumors, but there's white cells in there and other kinds of supporting cells that are normal, that are kind of co-opted by the cancer cells so they can form this mass. And some of those cells can actually support the growth of the cancer, we now believe. so that when we kill the cancer cell and we can kill the surrounding cells, we can have a much bigger impact. What makes this advance so interesting and so new is that it works against tumors that don't have an abundance of HER2, but have low levels of HER2 in them, what we call HER2 low. So we used to say HER2 positive and HER2 negative, but that's not a good term. Now we call it HER2 high and HER2 low and HER2 zero. Now HER2 zero, it's not going to work at all because there's nothing for it to attach to. But if it attaches to any HER2, even low HER2, it could have this profound effect. And what was reported, I'm proud to say, was reported by an investigator, Shanu Modi, who's here at Memorial Sloan Kettering, at a big national meeting. She got a standing ovation with tens of thousands of people. Is that when it not only can kill the cancer cells and control the growth of the cancer, but actually improves the survival of patients with low HER2. And this is important in and of itself because there's a lot of people who have low HER2, and before we had not a specific way to treat them. We had other drugs that worked, but this is a specific way to treat them. But it also indicates that we can make other drugs of this type. We call them antibody drug conjugates, an antibody and a drug conjugated together. And it's a very active field of cancer research now, making other antibody drug conjugates for other targets in addition to HER2. We have some of them already, and many more being developed right now. So it's a dramatic new approach to the treatment of cancer.
And the measure of the success of the treatment was how long people who received this treatment lived after it. And I gather the success was remarkable.
Well, it was very gratifying, in terms of actually seeing this improve. But I want to emphasize that that's not our goal. Our goal is not just to improve the length of somebody's life. Our goal is to have them return to a totally normal life and not have to worry about the cancer at all. And so these are all steps really in that direction. The work on PARP inhibitors that you just heard about and other things that we'll be talking about are all steps in the direction of actually eradicating the cancer cells so that they can never cause problems. So we're moving rapidly in that direction, and that's what gives us the greatest excitement. Not just prolonging survival, but we want to actually totally control the growth of the cancer. And all of us in the field think this is possible now because of what we've discovered about the nature of cancer, the nature of cancer biology, and great advances in what we call medicinal chemistry, making medicines that in the chemistry laboratory that can attack specific components of the cancer and control it in that particular way.
In terms of that knowledge that's been gained in recent years, is the U.S. at the forefront of that research?
Well, we have investigators all over the world, and indeed, Breast Cancer Research Foundation, which supports Susan and Yael's colleagues in Israel doing their work as well, really is now in dozens and dozens of countries. And what's really wonderful about modern cancer research is that we all work together, and we all work together extremely well. And we're seeing an international coordination now the way we haven't seen it before. And indeed, the Biden moonshot is going to help us in that regard. That's one of the major things that it's talking about, is to basically unite the world against cancer, because every human on this earth either has a cancer or could get a cancer. We're all either actual or potential cancer patients, and we're all in this together. So actually having that international cooperation is extremely important. But yes, we have a tremendous advantage in this country, which other countries don't have, is that we have a National Cancer Institute, a National Institute of Health. We have federal funding for cancer research, and that's really one of the major things that's put us in the position where we can make these discoveries.
You've been at this for a few years.
Yeah, as you can tell, right?
Yes. When you think of a patient, let's say with breast cancer 25, 30 years ago, right, and a patient today, how different is
there's no comparison.
Treatment and
there's no comparison. Well, I mean, it's not only the treatment, which we can talk about, but it's also the nature of the disease. Is that most of the cancers we used to see when I got started in this business, and I've been really doing this for about half a century, so that when I got started doing this, most of the cancers we saw were big because patients felt them, or their doctors felt them when they examined them in the breast, and so patients coming in with larger cancers have a much worse prognosis.
You mean that was the way the doctor diagnosed the cancer, was being able to feel it?
You feel it with the physical examination was an important thing. It was the very dawn of using diagnostic tests like mammography, which was the first test that really made a dramatic difference in terms of finding cancers when they're smaller. And so the kinds of patients that we're seeing now with little tiny cancers that are picked up by a mammogram or a sonogram or an MRI or something called contrast enhanced mammography. We made a lot of advances in what we call risk adjusted screening. People at higher risk may need different screening tools than people at average risk. Every woman is at high risk when you think about, we were talking about 10, 12, 13%. So you can't talk about zero risk or low risk in any woman, but there are relative degrees of risk. And as Susan just mentioned, there are some people at extraordinarily high risk because of abnormal genes that they've inherited. So we could do risk adjusted screening, but in doing that, we're finding much, much tinier cancers. And that, number one, conveys a better prognosis, but it also gives us opportunities to do things that we couldn't do then. Then we were doing mastectomies routinely. Not only that, but when I was in medical school, all the mastectomies were what's called radical mastectomies, where we removed not only the breast, but the muscles of the chest wall and all the contents of the armpit, a very disfiguring operation. Now we've evolved to the point that if people need mastectomy, they're just removing the breast tissue, leaving all the muscles intact. We have something called sentinel lymph node mapping and biopsy, where we can see if the lymph nodes under the arm contain cancer cells without operating, and therefore we only take out a few cells, a few lymph nodes at one time. And if they don't have cancer cells, we don't have to do any more surgery. That's a huge advance. And of course, many people are candidates for and elect to have breast conserving surgery, where we just take out the tumor. Mostly we have to irradiate the breast to prevent any other breast tumors from forming in the breast. But people have excellent cosmetic results where they have normal looking breasts, and yet we remove the tumor and we've reduced dramatically the chances of the cancer growing in that region. So that's been a huge advance. The other huge advance, if you're talking about 25, 30 years, is adjuvant therapy. We used to operate and then hope for the best. Now we can actually give medicines at the time of the surgery that dramatically decrease the chances of the cancer coming back. Hormone blocking drugs, other hormone manipulations for tumors that have sensitivity to that treatment. We can tell that by measuring the amount of estrogen receptor in the tumor. Chemotherapy drugs, which kill dividing cells. And there have been huge improvements in giving those drugs and minimizing the side effects of the therapy. It's not like the old days where the side effects were really severe. Most people can get this therapy with very good control of the side effects. And now other advances, such as you've just heard about, drugs that can, PARP inhibitors that actually, if the cancer has a predisposition to problems with repairing its DNA, we can block off that DNA repair and the cancer cells kill themselves. It's called apoptosis. It's cancer cell suicide, which occurs under those circumstances. And really many other advances, much to talk about in a short period of time. It's a dramatically different situation than it was 25 years ago. There's almost no comparison.
I want to ask about one other thing very briefly. I know you're involved in a young women's breast cancer program. How young is young, and how important is that?
Yeah, well, it's something that started here by colleagues of mine, both in the medicine and the surgery side here at Memorial Sloan Kettering. And first of all, we're seeing a higher incidence of breast cancer in younger people. Some of it is due to genetic susceptibility. Some of it is due to things we don't know in our environment. But young women have very different needs in terms of breast cancer therapy than older people. They're in their childbearing years. That's always a big issue. They may have young children to deal with. They're starting their careers. And so they really have a number of special issues. And that's one of the other important things that we've learned and we're getting better at over the years, is not just taking care of the tumor, but taking care of the whole patient. And taking care of all aspects of that person's life so they can go back as rapidly as possible and live a normal life.
Well, Dr. Norton, thank you very much. Stick with us because we'll come back to you in about 10 minutes.
Okay,
but thank you so much for joining us today. Larry Norton from Sloan Kettering. Thanks. Our third panelist joins us from her home in Israel. Dr. Yael Goldberg is head of the Adult Genetic and Cancer Genetic Unit at Rabin Medical Center. She's also deputy director of the Recanati Genetic Institute at Rabin Medical Center. In recent years, her work in Israel has focused mainly on both BRCA screening and also screening for Lynch syndrome, which predisposes people to colorectal cancer as well as other cancers. Dr. Yael Goldberg, thank you very much for taking part in today's panel.
Thank you for having me.
We'll come to Lynch syndrome second. It's frankly less well known to the public, and what I've learned from you is fascinating. But let's start with screening for BRCA genes. Israel obviously is home to a great many people of Ashkenazi ancestry. How is the project of screening for the BRCA genes going?
Around a year and a half, 2 years ago, the Ministry of Health in Israel has decided to implement population screening for the 3 Ashkenazi mutations for actually every Ashkenazi woman who wishes to do it from the age of 25 or 30. The decision to implement the screening is a result of lots of work that has been done by many geneticists in Israel, and you mentioned collaboration worldwide as well. I'll mention mainly Professor Levi Lahad, who really made it her life project. Mm-hmm. And it stems from several facts. One is, as we all know, the BRCA mutations are very common, very prevalent among Ashkenazi Jews. 1 to 40 Ashkenazi Jews is a carrier of a BRCA mutation. Then we found out, this was a work published in Science in 2003 by Mary Claire King, that around 50% of BRCA families do not really express family history of either breast or ovarian cancer until the first person to be affected is having the disease. So family history was not really a good hint in 50% of the cases. Then to decide of really population screening, one has to prove that families with no family history have the same risk as families with family history, and this has been proven as well. And the last thing has to do with our ability to prevent morbidity. And as we've heard from Susan and Larry, prevention of morbidity is possible among BRCA carriers. So with all of this in mind, the Ministry of Health got the decision to implement population screening. And this has been actually going pretty well, much more than we have expected.
Is it publicized in Israel? That is, or do doctors routinely tell their patients about it? How does the word get out to women?
So it took a while since the decision has been done. Today it is publicized in the media, in the Israeli Cancer Association, and actually most of primary physicians, gynecologists, advise their patients to come and be tested. We have preliminary data of 30,000 women who took the test in the last year. And they just, if they decide to take the test, they just go to the HMO. They have to fill up some forms, very little information. Nobody asks them if they're really Ashkenazi or not. Mm-hmm. They just want to do the test, so they do it. And we found out that, like we have predicted, similar percentage does carry the gene, and then we approached carriers. So it's been going on pretty well. Yeah. We have to deal now with the carriers. We have to provide them the right consultations and means for surveillance, and this is our challenge right now.
But just their prospects are greatly improved by the fact that that they have the gene. I mean, you can
definitely.
We always talk about Ashkenazi Jews, but you sent me an article that you were a co-author of, which reported on a study of Israeli women of Ethiopian ancestry or Ethiopian origins. And it was a recommendation to the Ministry of Health that they too should be screened for BRCA. It's not as prominent among that population as it is among the Ashkenazi population, is it?
Well, from our small study, it looks that it is as prominent. We found out around 2% carriers of 1 of 3 mutations among this small community of Ethiopian Jews. We also found out that the women who came to clinic with cancer had pretty aggressive breast or ovarian cancer, and that awareness was not very much great in this population. So this is a small study, as you mentioned. We now study a larger group. And if indeed the numbers will be the same, this is our recommendation, and we believe that this recommendation will be accepted.
Okay, I want to move on to Lynch syndrome, which is, I guess, a mutation. There are 5 different genes at issue, and the risk of colorectal cancer for somebody who has at least one of these mutations is hugely greater than not. But there are also many other cancers, endometrial and other cancers that are increased. Is there screening, similar routine screening, or of people to look for the genetic mutation that might cause Lynch syndrome?
So thank you for talking about Lynch syndrome.
Yeah.
For some reason, and we really do not know why, some genes have more PR than the others. And
You think that BRCA has better PR than...
yeah. But there are other cancer genes that we geneticists and oncologists are aware of. And one of the conditions which is pretty prevalent, some numbers talk about 1 to 300, some numbers talk about 1 to 500, is the Lynch syndrome. Lynch syndrome, called after Henry Lynch, Dr. Henry Lynch, is associated with high risk mainly of colorectal and endometrial cancer. However, it also associated with increased risk for ovarian cancer, pancreatic cancer, and other tumors. And the important message is that Lynch syndrome morbidity can be prevented or can be ameliorated if we just detect the carriers. So I don't think it merits population screening, but what is being done in Israel and is recommended in many other medical centers is to do what we call universal testing for everyone who had colorectal cancer or endometrial cancer, and to see whether the tumor has a signature of Lynch syndrome. And if there is such a signature, then genetic test is recommended, and then we'll look for the mutation. And from there on, we recommend, of course, cascade screening for family members and the right surveillance.
Since Israel does seem to, as we heard Dr. Domchek ruing earlier, Israel does a very good job in monitoring these numbers. Is Lynch syndrome more common among Ashkenazi Jews than among other Jews in Israel? Or is it also something that we picked up somewhere in Eastern Europe?
Well, I cannot say that it's more common. We do not have the numbers, but there are definitely founder mutations for Lynch syndrome among Ashkenazi Jews, but not only among Ashkenazi Jews. Mm-hmm. With regard to Lynch syndrome, we are aware of founder mutations about Jews from Iran, founder mutations among Jews from Georgia and other ethnic groups, as well as founder mutations among certain communities in the Arab population. And we established a very fruitful collaboration among gastroenterologists, oncologists, and geneticists, and we really try to raise awareness for this condition.
And just very briefly, although it probably deserves more time, but just what if anything is novel in the treatment of Lynch syndrome? What's new?
So the really exciting new, which is it's a novel, so we do not know where it will lead us, is the establishment or the start of clinical studies with vaccines for healthy Lynch syndrome carriers. Eventually, Lynch syndrome patients have multiple antigens in the blood, and this can be recognized by the immune system. So this led to very intensive research, and there are few centers in the US that have started with vaccinating healthy Lynch syndrome carriers. And no one knows if it will be successful, but it's definitely great news and very optimistic news.
Well, Dr. Goldberg, thank you. And I'd like to call back now Dr. Larry Norton and Dr. Susan Domchek. And to first, I want to take a look at some questions that have been submitted by viewers. One is, I have breast cancer in my family as a male. What should I do? Susan Domchek, what should our person in the audience do?
Well, I do think it's important that if there hasn't been genetic testing done and there's a strong family history of breast cancer, to have genetic testing done. Men who have BRCA2 mutations in particular are at increased risk for breast cancer, with lifetime risk of breast cancer in the 7 to 10% range. And there's kind of controversy about mammograms or not, but we do at least do breast exams, and in men who have breast tissue, we do mammograms. So risk stratification, often in a family that has genetic, that has a significant family history of breast cancer, starts with genetic testing. Because, and one more quick comment, if someone in the family has a BRCA mutation and this individual doesn't have that mutation, then that they're not at that risk. So that's why genetic testing can be valuable, both for people who test positive, but also for those who test negative in that family.
Larry Norton, any thoughts on that? I should add, by the way, the first question was from an anonymous attendee, but Regina Safti, who is watching, also asked, how about breast cancer in men?
Breast cancer does occur in men. A lot of men don't know it. And that's really one of the problems that we have with male breast cancer, is that they notice a lump and they say, well, I'm a man, I don't have breasts, I don't have to worry about it. And so when the cancer presents to us as doctors, it's usually advanced in men because they're not going for routine mammographic screening, obviously, and they don't know that they're at risk. So I think there's a very important educational component to this as well, that men should know that they can get breast cancer, and if they notice an abnormality in that region, they should tell somebody about it.
And one other thing, whether you're Jewish or not, if you have male breast cancer, you need genetic testing, because male breast cancer is rare, and at least 10% of men with breast cancer have a known genetic susceptibility.
This is a question that I have I'll put it to all three of you. I recently got an email selling a saliva test, which I was assured could possibly save my life. And the cost of the saliva test was $18. So I figured right away that can't be an actual business model, a result. For those who may not be familiar, in Hebrew, the letters that spell the word for life, Chai, when they're used as numerals, come out to 18. Right. So people give gifts in multiples of 18, for example. So when something is 18, it doesn't seem to, I'm sure it wasn't a business bottom line that arrived at that. Should I do that? Does it make sense?
What is the test for, Robert?
I believe it's for BRCA is what it's pitching, and it's in this particular case, I'll tell you, it's from a place called JScreen. I hadn't heard of it until recently.
I'm really going to let Yael answer that one.
I asked Yael when we spoke earlier. I mean, first of all, is there a genetic test that's that cheap, actually? $18, or am I selling something myself when I take part in such a genetic test?
Well, I'll give a basic answer, which is the devil's in the details of the test. There are different types of tests. And for instance, when you're testing just for the 3 common Ashkenazi Jewish founder mutations in BRCA1 and 2, the 3 most common mutations we find in people of Jewish descent, that's actually that's an easy test. And it actually can be cheap, although $18 is too cheap. That's a little bit like, the lead, I forget what the term is when you don't make any money to draw.
Loss leader, yes, a loss leader.
That's what it is. But, it's important to know that that's not what we call sequencing. That's not looking for all the spelling errors in BRCA1 and BRCA2. And so, if people have a strong family history, and particularly in the United States, where, what does it mean to be Ashkenazi Jewish? Robert, you and I talked about this. People, Is it one grandparent and who's Jewish in the family and who's not Jewish? And so, we're really careful to say that testing negative for the 3 Ashkenazi Jewish founder mutations, if you have a strong family history, is not sufficient genetic testing, both because there are many, many mutations in BRCA 1 and 2, and because there's other genes apart from BRCA 1 or 2. So it's really important to know, for people to know what they're getting in their $18 test.
And there's also a question of the accuracy of the test. Is it going to be done under careful circumstances? I believe strongly that these tests really should be done in a medical setting with some supervision of real experts, genetic counselors, people who really know how to interpret that. And I've seen tragedies with this where people were tested for the 3 common Ashkenazi mutations, came out negative, developed breast cancer, and then a subsequent testing had mutations in genes other than BRCA1 or BRCA2 that associate with their family history. PALB2, CHEK2, there's a whole large number of them. So I think that getting really good expert counseling is a very important part of genetic testing, and some of the work that Susan was commenting on earlier, and some of the other work that we're supporting in Israel is brings together real experts as well as the information. There's nothing substitute from having somebody who really knows what they're talking about interpret the test for you.
I would just add here, as Susan raised the point of who's Ashkenazi. This time I checked the numbers, and in the United States, where the Jewish community is overwhelmingly Ashkenazi, more than half of Jews who are married to someone who at least was not born Jewish at the very least. So there are many kids growing up who have an Ashkenazi parent. In Israel, I think we're up to 20% of Jewish births include both an Ashkenazi Jew and a Mizrahi, a North African Jew, is a number that I found online. So there are a lot of people who might be might have Ashkenazi ancestry, although they meant Yael, does that square with you, with what you know?
Yeah, and I really want to go on from what you've just mentioned. One of our main concerns with the population screening is the issue of false reassurance. We mention it, it's written, and we mentioned it again and again, that a woman who has a family history of breast cancer, ovarian cancer, or other cancer, and she comes negative in the population screening test, this should not be a reassurance that she doesn't have any other mutation. Mm-hmm. And this is one of our challenges. On one hand, we really wanted to implement this population screening because there is no other way to make many women come and get tested. On the other hand, we have to make sure that there will not be a false reassurance. And if you have a family history of cancer, those 3 mutations are not enough.
I'd like to add something to that, if I could, which is just that so many people think if they have no family history that they have no risk. Mm-hmm. And we're finding, in studies that we've done both in Israel and in the United States, is that half the people who are actually carrying these abnormal genes don't have a family history. They don't have an indication that they would have it. Mm-hmm. Not everybody knows their family. There's paternity issues, which we yes. also have to accept. Sometimes people keep secrets. I mean, people in previous generations have developed breast cancer and not told anybody because it was embarrassing, and so that they don't know about their family history. So the question of population screening is a very, very real one. And I just want to emphasize for the people that are listening here is if you think you don't have a family history, it doesn't mean that you're home free in terms of carrying some kind of genetic predisposition to something.
That's right. We have more questions from people who are watching. One is from Louisa Stern, who asks, can a previously negative BRCA on genetic testing mutate to positive?
Yeah, Susan? Well, Dr. Goldberg will have an answer too, I'm sure, but the simple answer is no. The longer answer is it depends on what test you had done and when, because in the beginning, we did sequencing, which basically is like doing spell check of a book, where you see spelling errors. It turns out that there's types of gene mutations where an entire chapter of a book is taken out or shoved back in. These are called large genomic rearrangements. And spell check doesn't see that, right? It doesn't notice if a chapter is gone. So it depends on when you've gotten testing, whether or not they actually looked for every kind of BRCA1 or 2 test, BRCA mutation. And as we mentioned, there are these other genes. So in general, if you've been tested like 5 years ago, it's worth sort of figuring out exactly what your test was. And maybe you had everything you need, but it's worth figuring out.
Yeah, we often see patients with impressive family history who come to our clinic and say, "Oh, but my mom was tested and she was told it's not genetic." This is the usual story. And what we try to explain, and I think this is our role now too, is that it's not that it's not genetics. The test that has been conducted did not reveal the genetic basis. And things are changing and evolving all the time. So it's not that the mutation was not there and now it appears. It's just that it could not be detected before. And we have to be very careful.
And Robert, you can get it from your father too.
In fact, I think
a lot of people say, my mother was fine,
Yeah.
her sisters were fine, so I don't really have any kind of risk, and they forget that there's a paternal side and there's DNA there as well.
Yael told me, Dr. Goldberg told me that actually you're finding that it is more often transmitted from the father, although the men are less likely to develop cancer in BRCA.
Most of the cases where there was no family history were apparently transmitted for the father in terms of BRCA.
Okay, I have to acknowledge 2 people in the audience have written about the $18 test that I mentioned. J-Screen, Lori Palma writes, is a legitimate organization through Emory Medical Center in Atlanta. And Peggy Cottrell writes, J-Screen is running a promotion now just for October, and the price is really $18. It's a panel test done by one of the major cancer genetic labs and requires that you submit your insurance. I defer to what they've said. Robert Olesh in the audience asks, please discuss genetic testing for prostate cancer. Larry Norton?
I think Susan is the best person for that.
Okay, Susan.
So for prostate cancer, we again think about BRCA2, but there are other genes, something called HOXP13 is one. And so Lynch syndrome has sort of been debated, but we do, when there's familial prostate cancer, that's another indication for genetic testing. Metastatic prostate cancer in the United States is its own indication for genetic testing. So, again, there are certain things, so you don't need to ask about a family history. Ovarian cancer, male breast cancer, metastatic prostate cancer, pancreatic cancer, breast cancer under 50. And actually, in the United States now, anyone of Ashkenazi Jewish descent will likely have their genetic testing covered. It's just a matter of, in the United States, we have to be really careful about when somebody comes in, if you ask, like, what religion are you? That is a very different question than what's your ethnicity and are you of Ashkenazi Jewish descent? So all these things play a role. But the short answer is yes, genetic testing is available for familial prostate cancer and for those who have metastatic prostate cancer.
In the time that remains, I want all of you to address the aims of the moonshot, that is, cut cancer deaths in half over the next 25 years. And I'd like to just hear is that, first of all, does it strike you as a realistic target? And if so, where would you, in that effort, where would you point the effort first? What would be the primary line of effort to try to
let me start this off. First of all, I think that's modest. I think that's a modest prediction. I think we're going to do much better than that, frankly, with the rapid development of modern science. A lot depends upon whether we can move that science actually into a situation where we help people. Susan mentioned death rates from breast cancer in the United States down by 40%, but that's not everybody is taking advantage, not everybody has access to all the advances that we've made. So that's one of the things that we have to work on, is to make sure that everybody can get the best diagnosis, prognostication, can get the best treatment. And that's one of the really nice things about the moonshot. One of the great things about the moonshot is that it's not putting all the eggs in any one basket. The intention is everything that could make sense here in terms of access to care, healthcare equities, research, international communications and cooperation that is looking very, very broadly. It's not any kind of one thing. It's like people ask me, where's the next advance going to come? And I say, well, I'll answer that question if you tell me what's the most important part of the airplane. Is it the left wing? Is it the right wing? Is it the landing apparatus? The fact is, all the pieces have to work together. And so what I'm very encouraged about in the moonshot is that it's paying attention to a lot of different aspects of the problem and trying to approach things in a very broad way. And that's why I think it's going to be successful, and actually it's going to exceed expectations is my prediction. And we're going to do much better than that in the next 25 years.
I'm going to skip to Dr. Yael Goldberg. Even though it's not part of it's not your president who's calling for the moonshot. Do you think those targets are reasonable and as easily achieved as Larry Norton seems to think they'll be?
Definitely. Yeah, I think we really have it there to convince people to do what the medical system can offer. For example, cascade screening among families with a genetic condition. Things that I'm telling myself every day: do sports and don't overeat, and use what the medical system has to offer, because most people do not use and do not do what, the recommendation that can be done. So with this and with the new therapies, and I'll even say go for potential vaccinations, I think we can definitely achieve it. And
stop smoking. That all by itself, if we could eliminate smoking from the population, that all by itself would have a huge impact.
Right. And Dr. Domchek, the last word is yours.
Well, that's unusual. But what I'm most excited about is not only working on prevention, all of these things that were mentioned, lifestyle, risk factors, but also this concept of cancer interception, which is as we understand more about the biology of the earliest lesions, the earliest cancer lesions, that maybe we can intercept at that point and not have to wait till they become a full-fledged cancer where we need to use chemotherapy, all the other things. So that's an area of basic science and clinical translational medicine that's particularly exciting, I think, over the next 25 years.
Well, I want to thank all of our guests, Dr. Susan Domchek of Penn, and Dr. Larry Norton of Sloan Kettering, and Dr. Yael Goldberg of Rabin Medical Center. Many thanks also to Joshua Plout, Nate Bonzani, and Roni Giuliano, and Adrian Kiss from American Friends of Rabin Medical Center, which produces Global Connections. And also thanks to our technical director, Bobby Grandone. Our program sponsor is the American Friends of Rabin Medical Center. It's a 501c3 national charitable organization which represents, in the United States, Israel's largest hospital, Rabin Medical Center, in Petach Tikva, Israel. That's in Greater Tel Aviv. The group's website, by the way, is www.afrmc.org. Join us next month for What's New in Washington, looking ahead to 2023. With our special guests, E.J. Dionne, columnist for The Washington Post, Tamara Keith of NPR News, and John Cassidy of The New Yorker. I'm Robert Siegel, and this has been Global Connections, navigating the new normal. See you next month. Stay healthy and stay safe.